All right, dog. What else? What else we got?
Third question today says, Happy Wednesday, Dave. I watched you via YouTube concerning hormone replacement therapy. I am 43 years old and live a fairly healthy lifestyle, but can tell that my level of vigor has decreased over the years. Where can I go to get all the truthful and complete information concerning hormone replacement therapy?
Here.
Yeah, I definitely can help you here. Actually, there's lots of places. I mean, I've learned from those before me, and it started with guys like John Lee, who deserve credit for this. And there's plenty of guys in history, including Dr. Jay Cott, in the area here, who ended up, bearing the brunt of some of the legalities back then. But there are plenty of pioneers in this space. I don't want to forget Jonathan Wright. And there are others, including, currently Dr. Lipschultz, who's, of a generation before mine, but also, still carrying the torch.
But they're not YouTube stars, so.
And what?
But they're not YouTube stars like you. I can't even take you anywhere. We went out to lunch. Oh my God, I see your videos.
I have to apologize for these on a frequent basis. I saw your video. Sorry about that. But the... I just want to make sure I don't leave anybody out. I won't be able to grab all the names, but Abraham Morgenthaler, a lot of fellows from Lipschultz, and probably some from for whom John Lee and Jonathan Wright were mentors. I don't know for sure, but there are plenty of good places. There are plenty of bad places, and that's what you want to avoid. Anyway, I hear that it helps to rejuvenate a person's energy, vitality, sex drive, and overall quality of life. Agreed. My concerns are effectiveness, safety / tolerability, and sustainability. Effectiveness, when done right, TRT is very effective, and it's a wonderful thing, and very safe. Tolerability, I don't know what you would tolerate, although there are potential side effects that really don't come with testosterone so much as what testosterone can be converted into. We mentioned estrogen and dihydrotestosterone earlier. Those are the two that can lead to, with dihydrotestosterone, acne and head hair loss and hair gain in the wrong places. The hair on the ears that we get as guys and whatnot. And for females, we always neglect to consider that men and women have hair in the same places as women, typically a lot less of it. So, hair on the chin or whatever. Those are potential side effects based upon your genes that can be controlled as long as we control the conversion from testosterone to excess dihydrotestosterone. And then with regard to safety, also, the biggest fly in the ointment for guys anyway is excess estrogen. Okay, because that can lead to, just as it can with females, water retention, fat retention, moodiness, and irascibility. But with males, you have the added issue with the prostate gland. And we know that certain estrogens, mainly of the estrone family, can activate the genes which we all carry for prostate cancer. So we definitely want to watch out for that, an overproduction of estrogen, again, particularly the estrones. And there are things you can do for that. Obviously, we use an AI. That's my preference. Although I have to say, even though I said that earlier about, in the last question about SERMs being difficult to use because you don't have an assay that you can use as a direct measure of, okay, this is what's affecting you directly. It's just an indirect estimate based upon clinical signs and symptoms. But there has been some research that shows that use of tamoxifen is protective against the COVID virus, up to 1,000-fold. Now that's in vitro, not in vivo.
What does that mean? What's the difference?
Well, that's in a test tube.
Okay.
So it might act differently in the body, but there was 1,000-fold increased protection using tamoxifen. So also with ACE inhibitors, but it's fairly credible. Again, it's not definitive because it's an in vitro test, but it jibes with some of the other items that they test, like an ACE inhibitor, like Norvasc, calcium channel blocker. Actually, the ACE inhibitor I don't think had the results, but calcium channel blocker, Norvasc, worked. There are other calcium channel blockers. They've been shown to protect against other viruses too. So it does make sense that the coronavirus would be affected. Anyway, that was a fun fact in case that probably won't even show up on Jeopardy. But anyway. Sustainability, you can stay on TRT, and I would argue you should, as long as you want to feel better and be better for life. I mean, we're replacing what Mother Nature has not provided us, whether male or female, so why not? He's got a list of questions, though. It says, what is the step-by-step process for taking hormone therapy? That's kind of a broad question, but I would suggest, as with all these questions and answers, seeing a professional, a doctor who specializes in this area. And unfortunately, typically right now, at least in this country, an endocrinologist is not the best one to see because, as I've alluded to many times before, I believe, the training for an endocrinologist is mainly in a hospital setting or a family practice setting. And certainly in the hospital setting, you don't see a whole lot of people being wheeled into the ER with low testosterone. It's usually diabetic ketoacidosis or thyroid storm. So endocrinologists get a lot of training in thyroid and pancreas, diabetes and thyroid issues, but not so much in hormone replacement therapy. In males, I would say, if you've got, I'm not a urologist, but, I specialize in this area. But as a general rule, a male should look to a urologist, preferably one that says, hey, we do specialize in this area, because there's urologists that will say, well, we'll work on other areas of urology, but not the hormonal aspect of a male being. And for females, I would say, again, this one's kind of tougher to recommend because while urologists are picking up the slack, if you will, in this area, I would say OBGYNs are not so much for the females. It's a gap in care, I would argue. So you might be stuck with someone like me unless you can find an OBGYN that says, oh, no, wait, I've done some study here and I can help you with hormones other than just the progesterone and estrogen and its effect on the uterus and having a period, modulating the cycle. And, you can modulate PMS with really successfully oftentimes with just progesterone. But to get to some of these other things like, energy, sense of well-being, libido, body composition, you're going to need the testosterone component. So again, that's how you get this process going. See someone who's qualified. I answered the second question, how long is one on hormone therapy? As long as you want to feel good, as long as there aren't any contraindications, which are very, very rare. And I would argue even when you have contraindications, it's for the wrong reason. So again, I would say for life with no exceptions. What are the side or unwanted effects? We addressed this multiple times. Acne, hair loss, or hair gain in the wrong places. What are the long-term effects of taking HRT? Feeling better, getting your libido back, your energy back, your sense of well-being back, and being able to leverage all the good things that you're supposed to do for health and body composition, particularly. Again, my point being that you still have to do the exercise, you still have to eat right, and you still have to rest properly. But now it'll be leveraged if you're on TRT so that you get the effect out of it that you're looking for. After you complete a cycle, will your natural ability to produce testosterone be increased where you stop needing to take HRT? That kind of begs the question. No, cycles refer to anabolic steroid use.
Here's the problem. That's most people see TRT as a cycle. Right. As something you do temporarily. They don't really understand that this is something long term. Yeah.
It's not a cure.
Yeah.
It's a treatment.
Right.
So TRT is replacing what the body will no longer produce. And there's a gray area there that probably leads to even more confusion. In the late 20s, early 30s, I've seen in practice you can get away with promoting endogenous production of testosterone, but at some point that doesn't work anymore, and you've got primary hypogonadism, not secondary. It's just the gonads, whether it's in a female, the ovaries, or a male, the testicles, they're just not going to produce the testosterone anymore, no matter how much you stimulate them. And so you have to go to replacement therapy, which again is not curative. It is a treatment that helps resolve the complaints and the issues. And cycles, that term really, I think, came about with the use of anabolic steroids. Remember, these are all steroids, but anabolic steroids are these molecules, whether it's dihydrotestosterone, that's been jiggered in such a way that when it enters the cell and affects the nucleus, the commands are to make more muscle tissue, more so than a testosterone molecule would do. And in some cases also, accelerates fat loss, like in some of the DHT derivatives like oxandrolone, stanozolol, the brand names most people know, Anavar, Winstrol, and Primobolan. Sorry, we lost track here with this. I keep hitting the wrong buttons over here. just want to make sure I'm on track with his questions and I don't go too far afield like I'm.
Yeah, he was asking about cycling and.
Sorry. So to pick up on the cycling part of it, the idea of cycling is you get on an anabolic steroid to be supra-physiologic, go above and beyond the norm in whatever it is you're trying to do, right? And most of it, in bodybuilding, they know it's okay to create more muscle mass, right? And there might be other reasons why you're doing this, but you go off of a cycle, a time period of being on anabolic steroid so that your endogenous production can resume and you don't lose it. I would argue, in my experience, you don't ever lose it, whether you're on for 5 years or 10 years or 3 months of a cycle, of a period where you're taking this, your body will start to produce as it did before, or in the case of, for example, if you're on it for 10 years, it's not gonna, if you started at age 40 and you stopped at age 50 for some reason, you're not gonna produce the same amount of testosterone you did at 40. You'll produce the same that you would have at 50 had you not done anything. Okay, right. So that's what I'm trying to say. But again, the idea of cycling is to not disrupt that endogenous production so much, and also to get off of an anabolic steroid, which comes with side effects, typically a reduction in good cholesterol, we call good cholesterol, and a increase in so-called bad cholesterol. And that's a whole other subject, which I don't necessarily buy into, but standard care right now says that's one of the reasons why, and effects potentially on liver, because it has to metabolize these substances, so we watch liver enzymes. But those are reasons why you would come off of an anabolic too. And I would argue there are other reasons for anti-aging purposes. Not the best, I don't love that word so much, but for regenerative medicine, for health span purposes, okay, for staying healthier and living longer, for not being on an anabolic steroid. You don't always necessarily want to be building, right? You don't always want to be making something in the kitchen, and at some point you got to clean up. You don't always want to be working out. Some people do, but you really don't. You have to have time to clean up and literally clean up and rest. Okay, so you don't always want to be on an anabolic. But he also asked, does HRT help with erectile dysfunction and premature ejaculation? It can. Certainly, if you're low in testosterone, increasing testosterone can affect your erectile function, and oftentimes low T is the sole reason for erectile dysfunction. There can be other reasons, particularly with regard to diet and cardiovascular health and nitric oxide production, which is a whole other topic. But to answer his question, also with regard to premature ejaculation, believe it or not, that's been used as a treatment, even in younger individuals. Increasing the testosterone can help treat premature ejaculation. And you would think it would be the other way around. Well, you give someone more libido, they're more likely to pull the trigger faster. Yeah. It actually doesn't work that way. And I won't bore you with well, maybe I'll bore you a little bit with a theory, but if you're not having to think about maintaining erections, right? The old joke about think about baseball, so you don't suffer from premature ejaculation. Well, if it's happening on its own, okay, then you can relax a little bit, and sympathetic nervous system is required. They're both required, parasympathetic to get an erection, but sympathetic stimulation to actually to have an ejaculation. So the idea being is you can relax a little bit and not suffer from premature ejaculation. The use of PDE5 inhibitors like Cialis, Viagra, and Levitra, and now Stendra are also good adjuncts to that process of trying to avoid premature ejaculation, for that same theory that you're not having to think about it to keep your erection. You can relax a little bit so there's not that sympathetic drive and premature ejaculation.
Nice.
Let's see what else. Do you have any referrals for the Nashville, Tennessee area? I do not.
But they can call you. People ask me all the time, and I'm not. I know you're not going to say it, so I'm going to say it. And many of you guys will ask me, send me a DM or an email asking me if Dr. Rand takes people from out of state or even out of the country, and he does. So you do Skype consultation, things like that. That's something you offer here.
Zoom. We don't Skype anymore.
Okay, I'm sorry. Online, I should say online consultation.
Telemedicine, yeah, they we're talking about now, and COVID has made that actually something that's even more prevalent. We do that. I that's not why we do these videos. As
I know, but they ask. So here you go. I'm sure this guy would be interested.
We're more than happy to treat you, but there are plenty of physicians out there. Never enough at this point, I don't think. And as I said earlier, I mean, if you don't want to come see us, or for some reason you don't want to fly out here, and you do want to sit in a physician's office to talk to them face to face rather than on Zoom, totally get that. There are other physicians out there. I'm sure there's some in Nashville.
How do you find them though? That's the problem, because
I would start with urology. Like I say, if it's a male or female, I would start with OBGYN, and then you got to ask the right questions. You got to say, do you do testosterone replacement therapy or bioidentical hormone replacement therapy? Not just for females is important, not just progesterone and estrogen. I mean, you do have to press it a little bit, and you might come up empty-handed and maybe even, I hate to say the word, but burned, and whoops, that's not the right one. And again, I don't know any fix for that except to at least steer in the right direction. But there are enough out there where if you search long enough, you'll find somebody in your area. You got to. I mean, if you're in Podunk, in the middle of nowhere, then yeah, you're at a loss. But come on, Nashville, there's got to be somebody in there.
I think people are just kind of apprehensive a little bit to ask those kinds of questions, and I think they enjoy the video because you seem so cool talking about it, and it's easy, so they can just call you.
They're always welcome to call us, and if we have any referrals, we will. Like, we refer in Tampa. Dr. Sayas there. I co-founded Defy Medical a long time ago.
Yeah, you were there for a lot.
Yeah, it just got to be too much. So my partner there found another a replacement for me. And Dr. Saya sees patients in Tampa. I mean, everyone's got a different style.
Nice.
But he's somebody who knows what he's doing. And there, I know, again, I know there's others in all the big cities. You just got to seek them out.
Yeah. Okay. Well. Just so you know, you guys, all the contact info, because he won't self-promote, but I'll say. So all the contact info are at the beginning of every single video, the emails, where to send the questions, and Dr. Kren's clinic, and his email, and phone numbers, and all that stuff. So anyway, thank you.
Thank you.
All right. Next.
Dear Dave, I've been watching and listening to all the questions and Doc's answers, and must say they are very helpful, and a big thanks to both of you for doing a great job.
Yes.
But one thing is bugging me. He's got a bunch of self-correct things going on here, so I'm trying to translate what's going on.
This is why you read the question.
And yeah, especially with a medical term, right? And couldn't find answers to it. I would appreciate very much if you could pass my question to Doc and let me know his opinion on it. I am aware that it would be just his opinion, and I should consult my doctor before taking any action.
He's been watching the shows.
Thank you. Recently, I've started to take medicine for anxiety, an SSRI, Paroxetine, 20 milligrams per day. I also have Ipamorelin, but don't want to use until I find out more. Can these two be combined? If yes, what would be best protocol? Once again, thank you for all advice and keep up the good work. Regards, Dejan from Slovenia in Europe. Cool.
Wow.
So, Dejan, I hope I'm pronouncing that right. First of all, an SSRI oftentimes will reduce your testosterone levels. Yeah, and so a lot of what we refer to as the psych meds, the psychology meds, atypical antipsychotics, typical antipsychotics, and I know this sounds like horrible words, but they're used to treat all kinds of things that don't sound as bad as the name is. An antipsychotic can be a helpful adjunct to SSRIs and others. So don't let the names get you too wigged out. But it can affect your endogenous production. So you got to be careful how you go about adding and subtracting from these. And yes, as you said, see a doctor first, but this is just some general advice. I don't know why you would have any contraindication, and certainly with Paroxetine and Ipamorelin, there's no contraindication, but why for this particular individual there would be an issue, I don't know. Talk to your doctor first. But Ipamorelin is going to help produce, it's going to tell your body, your pituitary, to make more growth hormone. That shouldn't affect in any way the SSRI. It might affect some of the side effects, we'll call them, of an SSRI. So a lot of people will get more somnolent, sleepy, and sleep better on an SSRI. Actually, especially in the early going, some people will sleep not as well on an SSRI. But one of the side effects of releasing growth hormone can often be the somnolence effect. So Ipamorelin could make that worse or compensate for the initial reaction to an SSRI. So again, my point being that it might actually be helpful, but there's no real crossover there. Does it help with anxiety? I don't know if there's any research saying that growth hormone would necessarily help you with, directly with anxiety. There's always going to be the case that when you're in better health and everything's more balanced, you're going to have less imbalance, and anxiety would be considered, right, an imbalance if there's no reason to be anxious. So I don't mean to be Byzantine or dodge the question, but I would say that these certainly two could be combined, just superficially. The best protocol, again, your SSRI, that's determined by your physician. Don't know what I can tell you about the Ipamorelin dose either. Everyone's different. There are starting doses, but those are just starting doses. So again, I look to your physician for that specifically. And this is a pretty simple question. I would encourage you to do all those things with your doctor. One consideration, Dejan, you don't mention your age, and I don't know. I shouldn't assume that you're male either, Dejan. I'm not familiar with that language, so maybe this is female. But see a urologist or see an OBGYN and ask about testosterone. Why do I mention that? Not because of, I'm thinking of the old Saturday Night Live skit from back in my day. Sorry, those of you who may remember, Shimmer. It's a floor wax. No, it's a dessert topping. Sorry. Anyway, testosterone does do a lot of really cool things. And one thing we've known since, again, the 1950s is that it can be used to treat depression and anxiety to some degree, right? In males or females. It's the feel-good hormone. Mm-hmm. And if you're feeling good, obviously you're less likely to be depressed or anxious. And there is a connection between anxiety and depression. So, it could be that there's an imbalance there. In my experience, and you can go back to the DSM-5, which in our country, in the U.S., is our sort of Bible of psychiatry, or psychology, but psychiatry more, I think. Depression, if it's part of you, if it's in your genes, usually reveals itself in your late teens or early 20s, okay? We prescribe SSRIs oftentimes later in life for what? It's going to happen to all of us, right? One of our parents dies and we're depressed for good reason, and we can use them to help smooth that period for 6 months, 12 months, okay? But then you get off them because it's not part of your nature to be depressed. But what's interesting about this that I've seen is what also happens about that same time. Mom and dad, at least in our culture, tend to leave us about the time we're in, or used to be anyway, we're in middle age. Well, what else happens in middle age? The drop off in hormones, okay? Mm-hmm. So during the same time period that mom or dad or some unfortunate event happens, we also have our decrease in testosterone occurring, and then people stay on these antidepressants for not just 6 months or max a year, but for years.
Double whammy.
Yeah, but it's not because of the initiating event anymore. It's because you've got low testosterone. Mm-hmm. And the way I try and suss this out in practice is to ask, well, first of all, when did you get started on it and why? Did you get started on your 17, 18, 19s or 21, 22, 23? Or was it at age 38, right after you got divorced or your parents died or both or, some reason? Mm-hmm. And how's it working for you now? Because what the SSRIs tend to do is they tend to just pull the plug on everything. So the lows aren't as low, but the highs aren't as high either. And they go, the typical expression actually is, it puts a blanket over everything. Which, okay, might be worth the trade-off when you're feeling miserable because something bad happened. But later, a year or two or more later, it's like, well, okay, I'm robbing Peter to pay Paul here. Mm. And so if it's just putting a blanket over everything, and all this has to be taken in context and should be done with a doctor, maybe it's at the same time, coincidentally, that was the straw that broke the camel's back, or was concurrent with that drop-off in testosterone, the feel-good hormone. And, I would say in my practice, we've had good experience actually, and again, better living through science. If it works for you, great. But if you're robbing Peter to pay Paul, you want to get off it. We've probably pulled off, I'll be conservative and say 90% of the people that were on SSRIs.
Wow.
Because of this.
That's
and
awesome.
we say, well, let's try this. That's why they came to us anyway. Something was off.
Yeah.
And eventually we can, and we don't pull it off from the beginning. Let's get you on T. And it's almost a given. They come in and say, yeah, I really feel great, right? I don't think I need my meds anymore, the SSRIs. And we do wean them off. And okay.
That's awesome.
Yeah. So hope that's helpful, Dejan, male or female.
Yeah. Awesome. Thanks, Doc. All right. What's next?
Hey, Doc, my name is Sam and I'm from Kentucky. I am 40 years old and I've been on TRT for the past year. I'm taking Sustanon 250, 1.25, I'm assuming mLs, every 3.5 days with a half tap of anastrozole the day after the injection. I don't lift. Why not? No. I'm a cardio guy, he says, that's why, which consists of running 1.5 miles every 2 days and playing drums, fast metal stuff. Overall, I feel great being on test. My last labs have me a little concerned. I have labs done every 3 months to keep an eye on things, which everything is great except for my most recent labs. Everything is good except for my PSA. It was 5.8. Oh, now I remember this. Yeah, this is why this is a good question. It was 5.8 and it usually stays under 2. I have watched every Acidoc episode, sorry about that, and I haven't heard you talk a lot about PSA levels. Well, you're about to get an earful now. I'm aware that there are things that can elevate PSA levels temporarily, like prostatitis, BPH, and sex, and passing a large stool, the day of the exam or the day before, riding your bicycle. Yes, there are a lot of reasons behind elevated PSA.
What is PSA?
Sorry, prostate-specific antigen.
Okay.
Something expressed from the prostate. And I choose that word carefully because, just even a digital rectal exam, can express prostate-specific antigen. Anything that manipulates the prostate can raise your serum level in the bloodstream. In other words, this assay. He says, my question is that I recently found out that you should be exercise or have sex up to 24 hours before giving labs. Probably means shouldn't exercise or have sex up to 24 to 48 hours before giving labs, but about 4 to 5 days before my labs. Okay, so he's I'm not sure what he's saying. Sorry, you guys, check your
grammar.
Well, that auto thing kills me too. Before my labs, I had sex every day and done my usual cardio and drumming. Could this be the cause of the 4-point elevation of my PSA? Absolutely. I have no family history at all of any cancer in my family. I'm a bit of a hypochondriac. Will join a lot of us. And I about lost it when I saw my labs with a PSA that high. I have never had any prostate issues of any kind ever. And I'm wondering, is this something that I should be concerned about? Because I would love to avoid, at least right now, the usual procedures like a digital rectal exam and all that. Thanks, Doc. That's the least of your worries. A DRE, oftentimes with an elevated PSA, typically not just one, but 2 consecutive or 2 over a certain time period, and they will recommend a biopsy, which comes with a bunch of risks, including impotence, inability to maintain an erection, or incontinence. Okay, so DRE, that's the least of your worries. And I have a big problem with the DRE too. I'll jump in here now. DRE, think about that. You're using your fingertip, okay, to try and evaluate something about the size of a walnut. They always use that example with your fingertip. And you're trying to evaluate for an inconsistency in texture, if you will, and any other abnormalities that you could pick up with your fingertip. Well, what do they say in sport, right? Baseball players, okay? Swinging the bat at the baseball, right? Takes 10,000 swings before you can become or think you can even begin to be professional at it or proficient at it or at a professional level, right? So 10,000 digital rectal exams. I did maybe a half dozen when I was on service in the hospital, when the attending would want to punish you for one reason or another, right? So, 10,000 before you're considered proficient in something that you go, okay, I think most people can hit a baseball bat better than they can analyze or evaluate a prostate with a fingertip, okay? So DRE, not the best, right? And while I'm on the subject, let's just throw in there, I argue the best, if you have any suspicion of irregularities with the prostate, a multi-parametric MRI is the best way to go. There's no irradiation there. They're picking up on, it's really using magnets and radio frequency to pick up on, to visualize this. And we can pick up on a lesion as small as 3 millimeters. That's very, very small. That's early stage cancer, or if it's not cancer, early stage anything. It's small. Okay, so back to his question. He says, I have never had any prostate issues of any kind ever, and I'm wondering, is this something that I should be concerned about? Because I would love to avoid, he says the usual procedures, etc. Thanks, Doc. By the way, if there's something I can take that will lower my DHT and prolactin, I'm taking 200 milligrams of B6 to help with the prolactin. Thanks again, Doc. Your feedback and channel are such a blessing and a valuable contribution. Thank you. So here's the thing. PSA, prostate-specific antigen, has never been a cancer screening tool. It is absolutely, and I'm not saying, remember I used to be an accountant before I'm a doctor, so presumably I'm honest and conservative, right? This is one of the most mind-blowing things in medicine to me today. Prostate-specific antigen, the assay, has never been and never will be a cancer screening tool. There have been books published about this. It has been printed in the Wall Street Journal. There's arguments about who invented the test, but one of those people, considered the inventor of the test, has gone public and said, please don't use my test, the PSA, as a cancer screening tool. Why? Because it's never been a cancer screening tool, and it's being used as such, and people are getting biopsies which have all kinds of risks attached for what would be considered, if it were truly a cancer screening tool, a false positive. Okay, but it's not a cancer screening tool. Again, this is what, I can't say it enough, and I'll stop, I think, because it's ridiculous. And yet it is part of the standard of care. I have to apologize to patients all the time. I put it on my laboratory assays because I feel like I'm going to get in trouble. Somebody's going to make a big deal out of it because I didn't check the PSA. My patients are, because I explained to them, it's not a cancer screening tool. Now, it can pick up on, you call it BPH, benign prostatic hypertrophy, so you'll have more of this expressed for some reason. Again, you ride the bike the day before, you have a bigger prostate, you'll have more PSA floating around your system. But it's, again, from riding the bike, and it's an enlarged prostate, not a cancerous one, et cetera, et cetera. Now, just to be technical here and just to make things as confusing as possible, it can be used in cancer. How? And I don't think this is a source of confusion, but I'm nipping it in the bud anyway. If you have a diagnosis and proven prostate cancer, and they do something like a radical prostatectomy, they remove your entire prostate, and then you do an assay of PSA and they find some prostate-specific antigen, then it's likely that you have cancer, prostate cancer, that has metastasized elsewhere. They removed the prostate, okay? If they did remove all of it, and there's no longer any smidge of prostate where it's supposed to be, then the presumption, therefore, would be, if you have PSA later, that there's metastasized prostate cancer elsewhere, lumbar, it could be any different number of places. But that would be the only way that PSA would be used. And it wouldn't be as a screening tool, it would be to detect cancer. So that's the only way that could be used. So forget about the PSA. And consider, just like we do with so many other disease states, any pathologies, colon cancer, coronary artery disease, breast cancer, at age 50, okay, and by the way, for those, age is the biggest risk factor for any of those. It's for most things. We degenerate. Things start to break down as we get older. So, okay, I can make a case for 45 like they do if you have a first-degree relative with any of those cancers to check even earlier. Why they pick 50 or 45, it is somewhat arbitrary. Where do you draw the line? But at some point when you draw a line, older in life, get these tests just because. So like you get a colonoscopy, get a multiparametric MRI, and just screen for prostate cancer. Because at this point in this country as of today, if you get it early enough, it's 97% treatable / curable.
Oh, wow.
Right? So yeah, this is one you don't want to procrastinate about and put your head in the sand over. It's expensive if you can't get insurance to pay for it. In this country, it's, probably a couple $1,000s. Yeah, I know. Well, it's an MRI, but it also uses contrast. And if you really want to get it down to 3 millimeters, I mean, any typical, it's a type of magnet, a 1.5 Tesla, as opposed to, say, a 2, or now they have a 7 in certain places. It's not necessary, but you'll get enough resolution to get a 5 millimeter lesion. But there's a guy in Holland who has special software that can get it down to 3 millimeters. So anyway, you're talking, it's not a small amount, but come on, guys. How important is your health? And prostate is a major killer in men. It's the second leading cause of cancer deaths in men. So heart disease, number 1, cancer, number 2, and in that cancer, it's the number 2 as of today in the U.S. So yeah, it's something it's worth the money, right? Now, arguably because of the misrepresentation of PSA and how it's used, you could petition your insurance company and say, well, I've got these consecutive elevated PSAs, so shouldn't I investigate further than a DRE? And maybe they'll cover the MRI. I don't know. Anyway, worth a try. But so to the rest of his question here, something to lower my DHT, yeah, we have the 5-alpha reductase inhibitors. In this country, we have finasteride or dutasteride. Finasteride works on 2 of the types, and dutasteride works on 3. I would always start with finasteride because it has a shorter half-life. If you have any side effects, which despite what you read is relatively rare, side effects being erectile dysfunction or a decrease in libido because it converts to, or you just don't have enough dihydrotestosterone, and that's important for some, for those things. But if you stop taking finasteride later in life, okay, and I say that because if you do anything too early while the HPA axis is still developing, like take finasteride when you're 15 years old, then you could have a permanent issue. That's what I believe. I've testified to that effect. And I think that's what you're hearing a lot about with finasteride syndrome, because like I've said on record before, in the cases of, adult males over 26 years of age and older, to be redundant, once you get off of finasteride, the syndrome, if you will, reverses. You get your erectile function back, et cetera. You get libido back, and everything works fine. But anyway, if you do have any of those issues, if you stop taking finasteride, typically within 2 to 3 weeks, they'll resolve, and you know that you just can't use that finasteride. But if it does work and you need more protection, dutasteride, as I said, works on the 3 types, and is even stronger. That has a 5-week half-life. So that's why I don't start with that, because you don't want to be stuck with that if you do have the relatively rare side effects. In terms of prolactin, I don't know about B6 being a fix for prolactin, but we do have things like bromocriptin and cabergoline, probably a better one that we can use. And then I would suggest talking to your doctor about those drugs for DHT and prolactin.
Awesome. Thanks, Doc.
Thank you.